Really, tonight's talk came out of a discussion about how could we, in the diocese, kind of support this whole year focusing on the family. And Father Fogliasso had a wonderful experience with Dr. Hilgers from the Paul VI Institute, and a number of us had friends in our different parishes who had benefited from the work there. So we thought we should bring somebody from Paul VI down to speak, and so here we are tonight. And so I also want to acknowledge, along with that, the generous support of the Gerber Institute, which is funding our speaker tonight. So I want to thank them for that as well. But Teresa has asked me to keep my introduction modest, so I will just say that we are happy to have tonight Teresa Kenny here from the Paul VI Institute in Nebraska. And she has been working there for 15 years. She just this year received an Excellence in Nursing Award from Omaha Magazine for her outstanding work supporting women and families in women's health and in family care. She has 8 kids and is going to be speaking to us tonight about the Creighton Model System and Naprotechnology. So please join me in welcoming Teresa to come speak with us.
Thank you so much for having me here tonight. I am a women's health nurse practitioner. So I'm one of those people that are in the mid-level. I'm not a doctor, but I'm also not a registered nurse. I'm kind of right in the middle there. And I went specifically into becoming a nurse practitioner because I was very pro-life when I was young. My mom had instilled that into me. She used to take me to the abortion clinics on Saturday mornings to pray. And I was even advised against becoming a nurse practitioner early on in my nursing career because my advisor said, Teresa, you're too pro-life, you're too Catholic, and you're going to have a really hard time being a women's health nurse practitioner. So I thought, that's probably true. But I thought, doesn't there have to be someone on the other side? So I was stubborn enough to kind of push myself through that program. I went to the University of Nebraska Medical Center College of Nursing and got my degree as a women's health nurse practitioner. And there were some struggles in that, but not too many that I couldn't overcome. But as I got out of my education, I realized I probably couldn't have a job, because who's going to hire a women's health nurse practitioner that doesn't prescribe birth control? Most women's health nurse practitioners are bred to be family planning nurse practitioners, meaning they're stuck in places like Planned Parenthood and other family planning clinics. I had heard about Dr. Hilgers at Pope Paul VI Institute. By doing some training, I had to choose my own preceptors that were kind of different than the Planned Parenthood mentality. So I worked in an area where I got to learn about what Dr. Hilgers' work was. And so after I finished my education, I wrote Dr. Hilgers a letter and said, this is who I am, and have you ever thought about having a nurse practitioner at Pope Paul VI Institute? And thankfully, he was very open to having me, and I've been there for the last 15 years. So this is what I live and breathe on a daily basis. I love talking about this work because I really do feel like what I do makes an impact not only in women's lives, but in families' lives. And the work is beautiful that we do, and it is spreading across the country and it's spreading across the world because it is a paradigm shift in the culture of life when we live in a culture of death. So I hope that you can learn a little bit about what we do. And it is kind of medical, it's more scientific on my presentation, but it's so that you can have a better education, understanding of how this all works, so that you can go out and evangelize that good news also. So of course, this all started with Dr. Thomas Hilgers. And when he was a medical student back in the 1960s, he would even say that he didn't really understand the issue of birth control, what kind of the church's argument was for or against it at the time. But as he was kind of finishing his 4th year, I think, in medical school, he had met a woman who eventually became his wife, Sue Hilgers. And in 1968, on July 25th, this document was released from the church called Humanae Vitae, an encyclical. And it was very difficult at the time to actually get a copy of Humanae Vitae, but there was a lot of buzz about the document. And at the time, there was a movement going on in the church for the position of birth control to be overturned, to be okay in Catholic Church teaching. In fact, the majority of theologians actually thought the church would overturn it. Since 1930, the majority of the Christian churches had started to change their position on birth control. So when Dr. Hilgers read this document for the first time, what particularly moved him was actually this passage right here out of the document. It's not very long, out of the encyclical, I should say. And he was very moved by the whole thing. But after he read it, he felt this call as a healthcare provider. I'm not going to read the whole thing, but Pope Paul VI's calling for people in the area of science and medicine to lift people out of the darkness, you could say, to try to find something more scientific in the area of fertility awareness, in the area of family planning, so that people had something that was more scientific, that was more friendly to helping people to plan their families. And so he felt that call, and him and his wife in the early 70s developed something called the Creighton Model System, or did their early research out on it, and actually that was, the earliest research was in St. Louis. The Creighton Model System was developed first, and that's where the science that he moved in towards, and he eventually became an OB/GYN doctor, and as he moved into the Creighton Model System and the work in that area, he found that what he was seeing over and over again in these charts that he was having women do, or couples do, a lot of evidence to show that certain patterns would show, infertility or PMS or abnormal bleeding. So it became kind of a gold mine for him to starting a new science. Naprotechnology is a new women's health science developed between the years of 1976 and 1991. It was the first ever reproductive health care that was completely consistent with Catholic teaching. Its development is the direct result of the standardization inherent to the Creighton Model System in coordination with extensive science and clinical research. This is some of the different things that Dr. Hilgers has published throughout the years. On the left is what we call the black book. This is a huge, huge book. It's over 1,100 pages. It's massive. It could hurt someone if dropped on your foot. Your foot would not survive it. But it is called, you can't see it very well, but the medical and surgical practices of Naprotechnology. That word, Naprotechnology, was actually coined by Dr. Hilgers. On the far right is a layperson's version of the science of Naprotechnology. So it's supposed to be a little bit more user-friendly, so that if you wanted kind of a little synopsis of the big black book, the Naprotechnology revolution could be read. And then he recently published this little book called The War on Woman, which is a collection of stories of women who have gone through a lot of harm, you could say, through current medical women's health care, and kind of what their stories were, what they had been through, and how they came through the Institute to get more help. And all of our publications, you can get, there's an order form in the back, and there's samples of those different books, except for the big black book I didn't bring. This is Dr. Thomas Hilgers in front of one of our kind of miracle baby boards. We have a lot of course, miracle babies. We have a lot of patients that come to us for infertility, particularly. Recently, I was with a patient, and this is just one of those moments where you realize kind of where our culture really is at. And all of you here probably know our culture is in a state of, just the direction is very ungodly. There's a lot of darkness in our world right now. But this particular woman had been infertile for several years, young actual woman, and she was talking about her experiences. She had been to a doctor before us that does IVF, a reproductive endocrinologist, and she was talking about her experiences with that IVF doctor. And she was telling me, she's like, I just never felt comfortable in that process. And she'd been through evaluation. I don't even think she intended that IVF was even an option for her, but she was, of course, seeking help. She wanted help for her infertility, and this is where her doctor directed her to go. And she said, I knew something was wrong as I passed that doctor's door, and on her office wall was a picture, and in the frame was a onesie, a baby's onesie, and it said on it, "Made by Maud." Now, the first name of that doctor is Maud. And she said, she just thought that was weird. And when she said it to me, I'm like, that's not weird. Like, that is like what Pope Paul VI prophesied. Like in Humana Vitae, what he spoke was that if we let contraception kind of become the way of the world, that men would start to act like God. That we would start using our bodies like machines. And that's what IVF is. Those artificial reproductive technologies are men making babies in test tubes. So made by Maud is real, but it also is very, very anti-God. And it is a slippery ethical slope that people, like this poor young woman, if she would have made that choice, would have never realized where it would go. And I'm certain, I've talked to people who have gone through IVF, they don't realize what is going to happen. Because as they choose to do the process, they have chosen then to sometimes make multiple children. 8 to 12 embryos in petri dishes, where a scientist decides which one looks good enough to keep. And then some of them are frozen. And then what if they implant more, like 3 or 4, that actually take inside the mother? And then they're forced to actually have an abortion to terminate some of those pregnancies. So it's not that IVF, there's a goodness that people are seeking and going the direction that they are. But what they don't realize is it's life for the sake of the death of others. And no one should be used for the sake of another person. This is some of our outreach programs. The first banner, Fertility Care for Young Women, that's kind of my baby project. It's for young people, college-age students, high school students even. It's a newsletter. There's a sample copy in the back table. I have about 13 issues, I think. Some of them address just simple women's health issues like painful periods, irregular cycles, polycystic ovaries, different things like that. And there's some other kind of chastity information and other just kind of fun stuff. So that's my newsletter. And then we have a Love and Life Unlimited conference, and that's directed for priests and also lay people that are very, maybe theology professors in ministries in the church, where they really want to delve into the church documents on human sexuality and life. So you're going to look really deeply into Humana Vitae, Donum Vitae, Evangelibus Vitae, all of those different encyclicals that really are delving into the human person and human sexuality. And then Building a Culture of Life in Women's Healthcare, that's just a newsletter the Institute puts out, I think, once every few months. And then on the right-hand side, we have a whole education program set up to educate people not only in the charting system, so we need teachers, we need people to be able to learn how to teach the Creighton Model system of charting. And then we need also doctors to be trained to do Naprotechnology. So there's a whole training program, and we usually get about 100 participants each year. A lot of them are doctors, a lot of them are lay people that are learning to become teachers. So again, you can see as we do this every year and these education programs spread, this is continuing to grow. So I encourage any of you who are interested in that, there is a packet in the back that explains those education programs in detail. So this is an infrastructure that has been in place for a long time. Again, Dr. Childress has taken very good care of this so that it's very, very scientific. Again, it's an education program that's very standardized and very objective so that it can be reproduced, it can be researched, and it's very, very credible. So the American Academy of Fertility Care Professionals was developed in 1981. It delves into the accreditation, the certification, and the service programs for fertility care practitioners. That word, fertility care practitioner, is just our charting teachers of the Creighton Model system. And then the Pope Paul VI Institute for the Study of Human Reproduction was founded in 1985, and we do research there, we do education, and we are a patient service education program, or patient service area too. We also have the Fertility Care Centers of America. That means that we have fertility care centers. So in Wichita, there's a fertility care center. I know Becky Knapp is here. She's a charting teacher for the Creighton Model System. So those fertility care centers are listed on a website. There's 275 of them currently. There may be more on fertilitycare.org. And then we have our Fertility Care Centers International. So we have worldwide affiliates. We have people in Mexico and Tanzania and Germany and Ireland and all places kind of. We've pretty much reached every continent in the United States. And again, our Love and Life Unlimited conference, again, is for priests and those people that are more interested in delving into the religious aspects and the ethical aspects of it. And we offer that once a year here in Omaha, but it's also offered in different areas. Some of the other things that have happened at the Pope Paul VI Institute with Creighton Model and Naprotechnology. In 2007, Dr. Hilgers launched a fellowship program. You can see Dr. Hilgers down in this picture with his son, Stephen Hilgers, who completed his fellowship in medical naprotechnology and surgical naprotechnology in 2013. And he actually became a lawyer before he ever considered going into the medical profession, and then decided being a lawyer wasn't what he desired, and then he went into medical school to become an OBGYN and completed his fellowship program. It was really just an incredible thing to see one of Dr. Hilgers' children, he has 5, go through this program, and he is on set to have another child go through the program in 2017, his only daughter, Teresa. So pretty cool, but that program is developed so that not only people can delve into the medical aspects of naprotechnology that we offer through our program every fall and every spring, but then they can get the absolute full surgical training that goes with it. And it's really important, especially when you're treating infertility patients, to have that component. We've trained about 17 physicians, I believe, at this point. Again, he leads every year. Dr. Hilgers does this training program in Omaha, Nebraska in the fall and in the spring for Naprotechnology and the Creighton Model System. And yeah, that's pretty much it. So Naprotechnology is about unleashing the power of a woman's cycle. And it's an exciting area of new research. Naprotechnology, which it's the first system to network family planning with a reproductive and gynecological health monitoring and maintenance. So it's the first time we ever can take something where you can use it for a natural family planning, but you also can use it to actually monitor your health as a woman. And these charts in particular are very, very specific at how we use them to look at different health factors, and we'll talk about that a little bit more. So again, the whole foundation of Naprotechnology is the Creighton Model System. Sometimes people will ask, you know, if they're doing a different charting system, let's say Symptothermal or Marquette system or Families of America, why can't we use that system and still kind of use it as a health monitoring system? And it's a language issue. So for anybody who's trained in the Creighton Model System, this speaks a very, very particular language. And it's been researched for 30 years to show us different patterns and different biological markers that are, you know, proven to tell us what certain things those things mean. If I look at a couple-to-couple league chart, I can't see those biological markers the same way. It has nothing to do with how effective it is for family planning, but it's just that it doesn't work the same way when you're looking at it for a health science. The Creighton model chart looks like this. It's a mucus-only system. So the only biological marker that women are observing in the Creighton model system is cervical mucus. And they track that on a daily basis. The woman tracks it and observes it. And that tells them each and every day whether they're fertile or infertile. And in this chart, of course, you can see if you use fertile days, then the Creighton model system is very effective, of course, for helping people achieve pregnancy. In fact, within 3 cycles, 95% of couples with normal fertility, if they use the Creighton model system, will achieve a pregnancy. And within 6 cycles, 98% have. Advances in the Creighton model system, again, it's an objective and universal language. So if I am, you know, in Germany, and I get a fertility care practitioner in Germany, they're going to teach it the exact same way that it's taught in Wichita or Omaha, Nebraska. So it's very objective information, but it's completely standardized so that it's taught over and over in a very specific way. It's a case management approach. So when we look case management approach, so when a chart is looked at month after month, that teacher is able to case manage it to help that couple be able to have success. And it's used to both achieve and avoid pregnancy. So it's truly the way we approach how we teach the Creighton model system is we're never telling people whether they should achieve or avoid. We're just giving them the education, and then they choose how to use the system for how they desire for their family. And so it's taught in a very neutral way in that sense. And that's an important thing because this is about couples being able to plan their families with God. We refer to this as the biological valve. This is why people can conceive pregnancy. So there's 3 things you need in order to have a baby occur. You have to have a sperm present, you have to have an egg present from the woman, and you absolutely have to have cervical mucus. Because sperm swim. And cervical mucus basically is the water that sperm swim through to get to the egg. So this biological valve is that when you are fertile, it's like a faucet cranking on to allow that cervical mucus to flow, and then the faucet cranking off after ovulation occurs, and then you have a pattern of dryness again. So the woman actually observes this period of fertility for a very short period of time, and she identifies that mucus and charts it accordingly. Estrogen is the hormone that actually helps the body produce cervical mucus. And you can see on the left that estrogen helps that mucus have certain properties that allow sperm to swim right through it. But if you produce progesterone, you're going to have a mucus that is an absolute barrier for sperm to go through. Therefore, post-ovulation, there's absolutely no way anybody gets pregnant. The actual window of fertility is very short for a variety of factors, but the actual egg that is there present once a month only lives for 12 to 24 hours. So it only has a very short period of time that it can be fertilized. That's extended a little bit by sperm survival in cervical mucus. So your actual fertility time probably is around 3 to 5 days at the most. So this is what it looks like. We've studied cycle after cycle after cycle, thousands of them hormonally, to understand the actual hormonal parameters of a menstrual cycle in coordination with the Creighton Model chart. On the left is the black bars are estrogen levels. You can see as estrogen rises significantly, that's when that cervical mucus starts to be noticed by the woman. She charts that as the white baby days. The green babies are all dryness. She's not seeing any cervical mucus. Of course, the red days is the start of her period. So as the estrogen rises again, she starts to see that cervical mucus, and then as ovulation passes, that's when you start to produce the hormone progesterone. That's in the gray bars. And then she goes back to a period of dryness again. So the days that she is fertile are the white baby days and the green baby days. So they're, again, very, very aware each and every day whether you're fertile or infertile. These are just fun. We have a fetal, we have an ultrasound department at Pope Paul VI, a very, very exceptional ultrasound department. And I like to show these pictures because they're just fun. And you just don't see this well in this picture at all. But it's really not. Let me just see if I can show you. This is a 6-week baby in a 3D image. And it's just, this is where you start when you talk about the pro-life movement. You know, showing these images, even to young people, helps them really see where the development of human life is. I might just leave that just dark for just a moment as I get through these pictures. This is a 10 to 12 week old baby. This is what I call the gummy bear dance. At 10 to 12 weeks, babies have really short arms and legs, and they do something like that. And it's not usually a time when you do ultrasound frequently, so it's always really fun. This is also a baby in 3D at 10 to 11 weeks. The baby learns to grasp objects at that point. It can grab onto its umbilical cord at 10 to 11 weeks, which is actually only 8 to 9 weeks when it's its actual development, because we always give them a couple extra weeks free. All its systems are developed, all its organs are developed, and it's really just growing after that point. This is a 38-week gestation baby. This is where you're just taking literally photographs of a baby's face. And one more. This baby's also about 32 to 33 weeks. They smile, they grimace, they do all the things that babies do. I love looking at babies on ultrasound. They're so fun. And again, what a testament to human life. I mean, at that point, if you're making a decision about abortion, if you see a little baby in the womb, you realize you're not really making a decision on whether it's tissue or a fetus at that point. I mean, it's a baby. It's very, very obvious. Any 2-year-old could point that out. So let's talk a little bit more about Naprotechnology. So Naprotechnology is about finding real solutions to real problems in women's health. Some of the things we look at are infertility, menstrual cramps, premenstrual syndrome, ovarian cysts, irregular and or abnormal bleeding, polycystic ovarian syndrome, repeat miscarriage, postpartum depression, prematurity prevention, hormonal abnormalities, chronic discharges, and some other things also. So again, it's about unraveling kind of the mysteries in that chart. The chart itself, we read them like systematically. It gives us this objective information that allows us to kind of decide, I think you might have this. I can't say this for sure, but your chart's showing me these particular biological markers, and we need to now do this evaluation to see if that's true. And we see these patterns over and over again. And for example, this might give you an idea of kind of what we might look at and say, okay, this looks like it could be a problem. The first line there is a cycle where the woman has 1 day of cervical mucus. If this is a pattern that occurs over and over again, if you think about what I said, that you have to have cervical mucus in order for conception to occur, this is a problem. And we can see people with absolutely no mucus, but we see more often people with what we call limited mucus. And this is a risk factor definitely for infertility. The second cycle is a risk factor for miscarriage. And that cycle, you can see that the P is there on cycle day 19, and she only has 5 days past that point. So the P is indicative of where ovulation occurs. And normally we should at least get 12 to 13 days past that. And she's only getting 5 days. That shows that she probably has a very strong progesterone issue and an ovulation issue. And it's likely that if even she could get pregnant, she would miscarry that baby. Low progesterone in the third cycle is indicative in the premenstrual bleeding. Some premenstrual bleeding can be normal, but if you get out to 3, 4, 5 days or more, that can be a sign of hormonal dysfunction, particularly low progesterone. Abnormal bleeding, something especially even in someone who's older, like in their 40s, abnormal bleeding like this could be something as severe as even uterine cancer. Most of the time it's not. It's something more of a hormonal issue, but the woman's awareness of what's going on in her body and the ability for a doctor to actually see that. There's no more poor historian than a woman who's trying to tell them what happened in the last month with their cycle. It's hard for me to remember what happened 2 days ago. So to actually have it documented is so helpful, not only for the person, but then for the doctor who's looking at it. So this is a normal Creighton model chart with normal estrogen and progesterone levels. Those estradiol levels tracked there would be considered normal. Her actual mucus cycle is normal. We can calculate all of those things and say, this is normal or this is abnormal. This particular cycle is a very normal cycle. This is how we take the chart and then we do a systematic hormonal profile. For most people who are coming, for example, for infertility, they would get a full evaluation of their hormones at the Institute. We would start, pre-ovulation or what we call pre-peak by about 5 to 6 days, and we do estrogen levels based on that, and then they identify their peak day, and we do post-ovulatory levels. When I have a patient that has gone to another doctor and has told me that they have had their hormone levels drawn before, I'll say, no, you haven't. Because nobody does this type of tracking. You cannot test anybody's progesterone levels unless you have them chart. Because hormone levels go like this. So unless you know where they were on that roller coaster, you have no idea what it's supposed to be. And the reference ranges they will look at are far and wide. So a lot of times people are just told your hormone levels are normal, or they'll tell them they're absolutely low when they were just pre-ovulatory, which happens all the time also. So it's amazing how much you actually know more than your doctor if you're charting in a lot of ways. But this is called a targeted hormonal assessment, and again, very few doctors know how to do this. This is just one case of a woman that I treated. She happened to be premenopausal, a 45-year-old woman who had had 8 pregnancies. She had 5 births, 5 children, and 3 miscarriages. She had a long history of irregular cycles, some pregnancy loss, low progesterone in pregnancy, and she was currently suffering from insomnia, anxiety, headaches, and premenstrual bleeding. So this is what her chart looked like, and you can see the premenstrual bleeding in those first 3 cycles. That is pretty significant. So what we did is a very targeted hormonal assessment of her progesterone and estrogen levels. Her progesterone levels are the pink line at the bottom. The normal progesterone levels is that middle black bar where it says 9.4 up to 15. So you can see we were able to assess that she has very, very deficient progesterone levels all the way really through her post-ovulatory phase. And her estrogen levels were also done. Those are fairly normal, so we're not so worried about that. But it is important to also assess that. And so we ended up cooperatively giving her progesterone. And this is also a really important part of Naprotechnology. You can't just give hormones on any given day, because if you're giving it on any given day, then you're messing with the actual hormonal fluctuations in the body. So it really has to be given cooperatively and timed with the cycle. So when we give progesterone, we actually time it very cooperatively with the post-ovulatory phase. It's actually true that only about 14% of cycles women ovulate on day 14. So if you're going to try to guess on how women should take their hormones, that doesn't really work out very well either. The peak day is the most reliable sign of ovulation. So 95% of the time, we've researched it with ovulation, with ultrasound. We look at ovulation and hormones over and over and again, but that peak day is proof positive that ovulation occurred within minus 1 to 2 days on one end of it and plus 1 to 2 days on the other end. So, and it's mostly 95% of the time within 1 day of the peak day on either end. So it's a very, very accurate indicator of the timing of ovulation. So again, with this chart, what we did is we used vaginal progesterone cooperatively, post-ovulatory peak plus 3 through 12. In that 4th and 5th cycle, the premenstrual bleeding completely went away. She ended up having a cervical issue in the last cycle that was treated, and that was also then went away after that. And she had reduction in some of her symptoms, slept better, felt better, and I'll explain a little bit more why that was the case too. So this is a situation where, again, we're using progesterone cooperatively in cycles. You can see in the top 3 cycles how she's a later ovulator, so that peak day is kind of out today, even 22. There may be nothing necessarily wrong with that, but it is a little bit later ovulation. It can make it difficult to chart. So in that case, that person was put on cooperative progesterone replacement, and you can see how the next 2 cycles actually she started, her body almost kind of fixed itself a little bit and went back to a little bit more normal ovulation pattern. So this is just really important to understand about hormones, because we all hear about hormones. We hear about birth control pills and all that kind of stuff. So when I give a hormone to a patient, what I explain to them is I will give you a bioidentical hormone only. And when I say that, I don't just mean natural, because natural can mean a variety of different things. So the more appropriate term is bioidentical, because it means that, and I like to think of chemistry, so that's why I'm showing this. If I take a molecule of progesterone out of my body, and I take a molecule of progesterone out of the medicine that I'm going to give that person, they will match up identically. And that's what makes it bioidentical. Therefore, the body accepts it as completely what is already made in its body. And there's usually very minimal side effects for that reason. Now, an artificial hormone, or Dr. Childress calls artemone, is similar to that hormone, but it will also have, other kind of chemical structures attached to it that make it artificial. And therefore, that hormone is not bioidentical, and it causes a lot more side effects, and it is extremely more potent, sometimes up to 400 times more potent than the hormone that's made in the body. So this is just one example. This is progesterone, the natural bioidentical form of it. And then Provera, which is a commonly prescribed progesterone for doctors, but again, it causes more side effects because it's artificial. And same thing goes for estradiol, an estrogen hormone. Suzanne Summers is someone who's just really into natural hormones, so that's why I have her picture there. That's an estrogen molecule. And then this is Premarin. Premarin we don't hear about as much, but for years, and it still is prescribed, it was just the mainstay of hormone treatment. And Premarin is estrogen extracted from horse urine. So you're getting horse estrogen when you take Premarin. And you can't even recreate that. You can't even make a generic version of that because each little batch of horse urine is different. So, but that's what women have been putting in their bodies for years. And it's completely synthetic, and it has a lot of risks to it. So the benefits of the bioidentical form of progesterone, we love progesterone and politics because it makes women feel better. And it has a lot of health benefits associated with it. It helps to maintain pregnancy. It's progesterone, which means progestation. It prevents premature labor, miscarriage, and other pregnancy complications. It reduces, relaxes your mood. It's an anxiolytic, is what we call it. It decreases blood pressure, reduces PMS, decreases water retention, protects your bones and your cardiovascular system, and it protects against uterine cancer, and it may also protect against breast cancer too, because it's protecting you from estrogen dominance. Infertility, we are kind of the IVF alternative. And infertility, we believe, is a symptom of an underlying problem. So it's not the diagnosis itself, it is actually a symptom of the actual diagnosis. So what we say is we're going to look for the underlying problem of that symptom of infertility, and we're going to correct all of those underlying issues so that your outcome of fertility is much higher. And so our success for infertility with these different factors is this much more successful than IVF. So with tubal occlusion, it's 1.4 times better than IVF. With endometriosis, 2.2 times better. With polycystic ovaries, it's 2.7 times better. And with anovulation, 3.2 times better than IVF. That doesn't really hit me, those kind of the way to say it. But basically, IVF is about 25 to 35% successful in a general kind of cycle-to-cycle basis. And we're about 60 to 80% effective for infertility. Sometimes it's simple, most of the time it's not. But this woman had dry cycles, and she was not getting pregnant, and she even quit charting, it says there in the second cycle. She's just frustrated. People get frustrated because they're not seeing what they're supposed to be seeing. And she came to Dr. Hilgers, and the first thing he did was, I think she was a younger person, he just said, well, okay, well, you've got dry cycles. She had started some heavier exercising, I think, for a while. He said, we'll put you on this vitamin B6 500 sustained release, and we'll see what happens. So he put her on that vitamin, and she really didn't have that much mucus. But this is important when we talk about fertility-focused intercourse. She knew the right day to use. It was one day that she needed, and she was able to achieve a pregnancy. And that's her picture of her little baby there. This is just, you think about that chart I showed you with all the hormonal profile that was normal. This would be one that we look at that's abnormal. And it goes with an abnormal chart, of course. You can see in the chart she's got a lot of premenstrual bleeding, she's got limited mucus, and her hormone levels are going to show that also. This is surgical Naprotechnology, especially for infertility, but for also pain issues and other women's health issues like polycystic ovaries. We do surgery. We do a lot of repair of endometriosis. This is a very, very meticulous type of surgery. So a lot of people will come to us when they've already had surgery done by other doctors. At least 75, probably 85% of the time, those surgeries were done incorrectly. Not because they were bad doctors, but we've dealt with a culture that has used the birth control pill for 50 plus years now. These doctors aren't getting trained to do surgery correctly. So these people are not getting a correct diagnosis, and they're not getting correct repair of their disease. Endometriosis is a very toxic disease. When I explain it to patients, I'll say it's somewhat like cancer. It isn't cancer, but if someone told me I had cancer tumors all within my pelvis, I would sure hope that the surgeon that I had was going to go in and get every little bit of cancer that was in there. And for the same reason, you need a surgeon who is going to diagnose endometriosis and actually remove it 100% meticulously. Otherwise, your outcomes for not only fertility, but for your pain and quality of life are going to be, down significantly. And so these doctors that come through the fellowship program, they're very, very specifically trained how to do surgery. And there's not very many doctors out there, unfortunately, who really know how to do it well. We also have a great success in treating polycystic ovaries with something called the ovarian wedge resection. The wedge is amazing. We just redid all of our calculations for infertility, and it's 80% successful for treating infertility in the first 18 months. And most of those couples actually got pregnant within the first year for sure. So it's a correction of the actual disease, and nobody else offers this because we've had Clomid out for so long that people just stopped looking into the actual correction of the disease itself. Naprotechnology works by assessing the underlying causes of reproductive abnormality. It allows for the treatment of those underlying causes. It assists the couple in achieving pregnancy while maintaining the natural act of procreation. Again, it follows Catholic Church teaching completely. If the treatment program is unsuccessful, research into the unknown cause is undertaken. If medically unsuccessful, the program will assist with successful family building by being supportive of adoption. So we always say if we can't help every person to have a biological child, which we can't, we want to help them build their family in any way possible. And I have those conversations, weekly with patients. We want to always be honest and fair with people, but also just allow that openness. God wants to bless people in all sorts of unique ways. And really God calls us to be open to love and life. And that may not always be a biological child. So we have to help them find what that is. So if you can hang in with me for a little bit longer, I want to share a few stories about patients that have come to the Institute. These are patients that have allowed me to share their stories with you. This young woman, sweetest little South Carolina girl, worked in the NICU for years and was infertile for at least 8+ years before she found us. And she went through all of our evaluation and surgery, and she was trying to get pregnant for a long time. This was a quote, part of her testimony. We got married in July of 2006. We were open to having a family right away, and both our parents struggled with infertility. So in the back of my mind, I always thought I would too. Unfortunately, that did end up being the case. So she really suffered for a lot of years, again, working with little babies every day and not being able to carry a baby of her own. So she was right kind of at the end of her rope, you could say. And it was around Christmas time. I remember we were doing a John Paul II novena, and we were really praying for all of our infertility patients, but she was special, so we were praying for her hard. And she gave up treatment in that December cycle, and that's the month that God blessed her. And here's her little baby. So this year, that little baby will turn 1 year old. And that's her sweet little family. This is about a patient that dealt with prematurity. We have a whole prematurity prevention program. Again, I could talk for hours about all this stuff. But this young woman had sent this testimony to me, and I'll just read it to you. I wanted to thank everyone at the Pope Paul VI Institute for taking such wonderful care of me and my baby. Today I am 25 weeks and 3 days pregnant, which wouldn't mean much to most people. To me, it is a major milestone. My first baby, Danny, was born on this exact day during his pregnancy. With each subsequent baby, it's hard not to relive the events that brought me to a preterm birth and the 4 months we spent in the NICU watching our son fight through multiple surgeries, perforated bowels, brain hemorrhages, problems with his heart, retinopathy, and being ventilated for more than 2 months. I want to thank each and every one of you for being my guardian angels and always looking out for my best interests. I know in my heart of hearts that I'm getting the best care in the world and that I'm going to a place that feels like home. At this point, I've had no signs of preterm labor, and I attribute that to all of you. My husband and I couldn't thank you enough for helping build the family we've always dreamed of. God bless Hope. And so her little boy that was premature there is on the left, on the right actually, and then she had a healthy baby at full term. She's actually had another healthy baby at full term also, so she has 3 little babies now. So with our prematurity prevention program, the national rate is about 12% for prematurity, and we're at about 4%. And it goes into a variety of things that we do. One of my favorite protocols in the whole world is our postpartum depression protocol. It's absolutely phenomenal and helps so many women at a time when they absolutely are crying for help. This young woman had suffered with postpartum depression for most of her pregnancies until this last little baby. Having suffered with miserable depression and anxiety after my last 4 pregnancies, I was desperate to find an effective treatment for postpartum depression before the arrival of my 5th child. Well, at an NFP forum at a nearby parish, I heard it mentioned that the Pope Paul VI Institute had a protocol for treating postpartum depression with progesterone. I had long suspected that the sadness and anxiety I experienced in the days and weeks immediately following the births of my other children was a hormone-related issue, and I yet never, despite discussions with my various OBGYN doctors over the years, had one suggest progesterone as a form of treatment. So I called the Pope Paul VI Institute the very next day to find out more. I was put in touch with a wonderful nurse that explained Dr. Hilger's research and the reasons for using progesterone to treat PPD. For the first time in years, I felt hope. With the arrival of my new baby, I was not going to plummet into that all too familiar tunnel of darkness. Knowing how hard and fast I fall emotionally after my babies are born, I actually took my first dose of progesterone before I even left the hospital after giving birth, and have been continuing with the injections for the past 4 weeks. To my absolute delight, I can say that this postpartum period has been totally different. No sadness, no anxiety. It all feels like a miracle. Instead of wishing away my precious son's infancy, I am actually enjoying it. Thanks be to God, this is a season redeemed. I am so grateful to everyone at Pope Paul VI Institute and for all that they do to help women both physically and emotionally. Please keep up the good work, and God bless you all. Catherine. So, I mean, this story, I could tell this story 100 times with 100 different women, because, I mean, this story is not unique. When I get a patient that has postpartum depression, she'll have all the symptoms. We have 17 symptoms in our checklist. She usually has all of them. And I can reverse those symptoms in 24 hours. I mean, who can do that? It's absolutely phenomenal. So this is an actual miracle treatment, and we are always happy to offer it to women. This is a woman who actually received the wedge resection. Heidi was one of Dr. Hilger's patients, performed a pelvic laparoscopy on me in October of 2008 and an ovarian wedge resection in 2012, along with Dr. Jamelka. If it weren't for them and for all of you wonderful nurses and staff at Pope Paul, our son Patrick wouldn't be here today, and we are so grateful. He is perfect, thank you. And this was her. She had actually written also her own kind of infertility story in her, I think, her own church newsletter. Right.
Somebody who's just having trouble.
Right. So, and you talking as young as maybe even like a 13-year-old, a 14-year-old. So I don't necessarily think that everybody that age needs to go through formal training in a form of charting like this. But I have a 14-year-old, and we talk about mucus, and we talk about why you have that stuff. And I'm not talking like we get into great detail about it, but she's very body aware now that, and I tell her, I mean, the one thing that you can do with the teenagers is say, hey, if you notice that mucus stuff, you can predict when your period's going to start literally to the day. Then they can say, okay, well, that's kind of cool. But for an adolescent that has problems, let's say you're reaching 16, 17, 18, there is great value in charting. And if you can, especially in college, I mean, it makes perfect sense to start charting in college for a variety of reasons. But first and foremost, because most people will search their spouse out or find their spouse in college or shortly after. So it's a great way to introduce them to the natural way to family plan by having them chart. But most girls are at least very open to the idea of being aware of what their body does. There's a true feminism in that. But I think from the youngest ages is just start having the conversation of how God made you and how the design of our cycles is so unique and beautiful, and how that design will allow you to become a mother someday. And then, you talk about what those biological markers are. And if they can kind of track them in their phone or, start with that to begin with, that's great. But when you start to have health issues, again, using the Creighton Model System is very specific to that.
Is that hard to learn? Because it looks really complicated.
Well, we always say in our introductory session is that it's very easy to learn. And it's very easy to interpret, so we're selling it as easy. I can't, if I could go through an entire introductory session and explain to you how it all works, then you'd be like, okay, it's a lot of knowledge. It is an education, for sure. But once you have the education, just like if you're learning math and algebra, was it hard at the beginning for you? I'm sure it was. Fractions were hard for me. But after you start doing them, for a couple of months, it becomes easy. And then it's secondhand knowledge to the point where couples are using NFP month after month, year after year. They don't think about it very much. They just live it.
What are things that we can do to support Naprotechnology in our community? And clearly not very well received in conventional medicine. There's a huge call for it. I mean, it's a gap in women's health care.
So first and foremost, you worry about yourself, because you take care of yourself first. Because if you can't, like it says in Scripture, find a splinter in your own eye, you can't see the log in, somewhere, fix the log in someone else's. So we worry about ourselves first. If I can, in my own home, live out a natural family planning, the beauty of God's plan in that, and show true Christian joy, which is hard with 8 kids, then I am first and foremost a witness to that evangelization and the gospel of truth. And that's what we can do first. And then what you do is, as people see your joy, they will come to you. And that's why people were fascinated with Jesus. People came from all over because they witnessed something that was unique in him. So first and foremost, you have to attract people to you by your own Christian joy. And then what happens is that things just spread by word of mouth. So then you meet someone who says, I just miscarried my second baby. I don't know what to do. My doctor doesn't have really any answers. And you say, well, I happen to hear about this place that really does something different and unique. And, maybe I could share that information with you. The openness to natural family planning is hard, but that is a complex issue, and we need a lot of work done in our church with our whole structure of the church and the way we teach those things. But it's starting to change. I mean, I have been in marriage preparation for years now, and the way we teach about natural family planning is being more well received, I think. But we have to go back to the cross, because natural family planning is not about making it like contraception, because we sell contraception as easy and convenient, and that's not what natural family planning is. It's going to the cross. So we have to sell the cross and sell it as the way to actual happiness and joy.
What is the standard treatment for endometriosis?
So the standard treatment is to first diagnose it. First and foremost, it almost never hardly gets diagnosed correctly. So again, most often what happens is if a woman has really painful periods or pain with intercourse, she gets put on the pill. She may get told, you probably have endometriosis, but no one really diagnosed it. The proper way to diagnose endometriosis is to do a diagnostic laparoscopy. I say all the time to my patients, if you had stomach problems and you went to a GI doctor and they gave you medicine, you kept having stomach problems, and they give you a different medicine, when you came back and you kept having stomach problems, they would do a colonoscopy in a heartbeat. Or they would do an endoscopy in a heartbeat. So a laparoscopy is a way for an OBGYN to look for the problem once medical therapy has failed. And not very many doctors do them. Hardly ever. Again, we just have this easy pill that makes people go away from them. And they're not trained very well in it either. But first and foremost, you do a laparoscopy and you diagnose it. And then it is about actual removal. And that could be laser vaporization of the tissue that's abnormal, which is what endometriosis is. Again, very similar to cancer. It's an abnormal formation of tissue. Or you dissect those endometriosis implants and meticulously repair the tissues. And then we have all sorts of adhesion prevention techniques. So it's a very complex kind of meticulous type of surgery that we take very strong care of. But not very many doctors do it that way. We see patients all the time that had surgery for endometriosis, and we'll read the operative reports and they're like, well, it was a mess in there. We took care of what we could, and we kind of cauterized some, and then they're gone. They came out and they left it. And then they advise them to go on the pill or something stronger like Lupron. So again, thinking of the analogy of cancer, if someone told me I had cancer, I want a surgeon who knows how to do it right. And the same thing goes with endometriosis. Get it taken out right the first time.
Are there ever hysterectomies for this? I feel like I know people that have hysterectomies when this is probably...
Yeah, and we don't do hysterectomies very often because we like to keep people's organs and we like to do pelvic restoration. So we don't do them very often. Not that they're not necessary at sometimes, they certainly are, but generally endometriosis is not a need for a hysterectomy. That can be repaired.
But do they do hysterectomies?
Other doctors?
Yes.
Yes. In fact, I've seen a hysterectomy in a woman as young as 23. I mean, a disaster. In fact, complete medical negligence. It's just absolutely disastrous. You know, and those poor women, you know, they don't know what they're doing. They just want the pain to stop. They want the problem to go away. So it's almost completely unnecessary.
There are hundreds, if not thousands, of period or fertility tracking apps out there. Is there one for the Creighton model, or is there one in development that you would recommend?
There is one in development. But I'm not promising when it's coming out. It's been in development. Everything, I think this is true of all Catholic things, whatever, I don't know, it's slow. And Dr. Hildress, of course, is very, very, very controlling of, because if he's going to put something out there like an app, he is going to make sure it works exactly the same way as it did on paper. So he has to research it first. And so it's in the works, it's being researched, and we hope it will come out. It will come out. There are other apps, of course, for other systems, but there is nothing that is Creighton model out there now. There's a Billings ovulation method app called NFP charting. I know some people are using that. I was, again, saying at the dinner that there are a lot of people using fertility apps, and I joke often as I find a young person who comes in with their phone and tells me that she's charting, and that, you know, she's going to ovulate in a week. Her phone told her so. And I'm like, okay. And I think, dear Lord, we have now reversed ourselves back to the rhythm method, because our high technology phone has now restored us to tracking previous cycles and telling our body when we're going to ovulate. And, you know, it's a big problem. So you have to make sure, again, it's just women need to take responsibility for having the knowledge. This is about true feminism. Like, let's figure this out, what our bodies really are telling us.
I realize you said there's a very meticulous language with Creighton model. Is there any room for those clear blue ovulation monitors? What's Dr. Hildress' thought on this? I don't think it's very possible.
Well, it's not that, I mean, how should I say it? Would he say that it's necessary at all in the Creighton model system? Absolutely not. Because he would believe that the Creighton model system can tell you everything that you need to know. Now, patients are using those monitors. The problem, his biggest problem with it is that a lot of times with patients who are using it because of infertility is that they think that their monitor is telling them that they're ovulating. But that hormone that measures cannot tell them if they're ovulating for proof positive. It can tell them that they are having a questionable ovulation event. And so it can give them a false sense of security in that situation. But yeah, he would advise not to use it, but I mean, I know people are out there doing it. I don't think it necessarily is going to cause harm until what happens is that, I mean, they're not even charting anymore. They're just using the monitor. So.